Little history on her. She did her internship and her residency at the University of Tennessee in Chattanooga. She also did a clinical rotation, or went to infectious disease fellowship in the University of Florida in Jacksonville. She did a clinical rotation down there at the Mayo Clinic in Jacksonville. She serves on our infection control committee. Also is in the process of forming an antibiotic subcommittee. She likes infection control, of course, epidemiology, and treatment of C. diff, and antibiotic. She's on antibiotic stewardship. And I will let her talk with y'all, okay?
Thank you, Carol. Can everyone hear me? Or can everyone hear me? Okay, so everyone ready to talk about the bugs? Good. Yes. So I'm going to focus today about multi-drug resistant organisms and C. difficile. And the one we all know about is MRSA. We've heard about it for a long time and there's been a lot of attention, but there are a lot of other organisms that also are multi-drug resistant, and that's what I want to focus on today in my talk, because we're seeing more and more of them. And basically the definition for multi-drug resistant organism is any microorganism that is resistant to one or more classes of antimicrobial agents. And if we exclude MRSA, I'm not going to talk about MRSA because we've talked about that in the past. I'm just going to focus on VRE, or vancomycin-resistant enterococci, extended spectrum beta-lactamase producing gram-negative bacteria, that's a long one, ESBLs, as they are called, and carbapramase producing organisms. The new name for them is CPO. Some of you may know them by the name KPCs. And at the end, I'm going to talk about the C. difficile infection. What do we need to know about them? Evidence has shown that there is increased length of hospital stay because most of these patients end up with IV antibiotics for longer durations, increased hospital cost, increased risk of surgical procedures, increased ICU stay, increased mortality, morbidity, and all these things. So I'm going to start with a case. 84-year-old female who got admitted from a nursing home. This is a case scenario we see very commonly. The patient had end-stage renal disease. She was a dialysis patient. She had a dialysis catheter. She also was diabetic, had heart disease, peripheral neuropathy, peripheral vascular disease, had a stroke in the past, and was in the nursing home. Came in with high fevers, was hypotensive, tachycardic, confused, white count up to 20,000 bands. Obviously her creatinine is going to be abnormal because she's a dialysis patient, had a lactic acid of 4.0, basically a septic patient. And we see this very commonly, most common, patients coming in with septic, they get started on vancomycin, peptazo, the azocin, which is the trade name that we all know. Her blood cultures are reported positive for gram-positive cocci. I want to give a little background about this. So we're going to do a little review of microbiology here because the lab calls and says gram-positive cocci. What are they? What are the families of bacteria that fall under gram-positive cocci? What are gram-negatives, and why do we know about them in this talk? I'm not going to go into details of this, but just to say, if you look at this green, just concentrate on this one. This is called the peptidoglycan layer. And that one is very thin in the gram-negatives. So this is just the talk. So the gram-positives are going to appear purple when you look under the microscope in the gram stain. And the gram-negatives, because the crystal violet gets washed away, we just do a counter stain called saccharin, so they appear pink. So that's the difference between gram-positives and gram-negatives. And let me give you some examples of gram-positives. Here, if you're seeing, I don't know if you see the color properly, these are round, these are purple, and they're in clusters. So these are gram-positive cocci in clusters. And this is from an abscess from a patient who had MRSA. So I don't have a pointer. And if you see here, these are purple, these are round, these are in chains. These are gram-positive cocci in chains, and this is strep. And this is a sputum from a patient who had MRSA pneumonia. These are round, these are purple, and these are in clusters, gram-positive cocci in clusters. This is Staph aureus from a sputum in a patient with Staph aureus pneumonia. You see here, these are more like rods, and they are pink. So these are gram-negative bacilli, and this is Klebsiella pneumonia in a patient with community-acquired pneumonia. And again, if you see here, these are round, these are in pairs. So gram-positive, diplococci. This is strep pneumo.
I think it's just.
Oh, is
Oh,
there
there
a
we go.
pointer?
It's right there.
Okay.
I had to.
This is,
Yeah, there
okay,
you go.
good. So let's go back to our case again. So this patient had blood cultures positive for MRSA. What does the patient get? 4 weeks of IV vancomycin. Her dialysis catheter was removed. She got a new one placed. Her blood cultures were negative. The reason we treat staph bacteremia for so long is because staph is notorious to cause recurrent infections and also metastatic infections like endocarditis, brain abscess, and such. So gets readmitted again. So going to the next admission. Patient is again back with fever, white count, back from the nursing home. All the cultures are done, and what does she get started on? Vancomycin and zosyn again. And this happens quite often. Patients come back and they have a fever, they're coming from nursing home, we don't know what's going on, chest x-ray has no pneumonia. Just based on these findings, okay, the nursing home said she had a fever and there's a mild white count of 11,000. Let's throw in all the antibiotics. All the workup is negative. And after 5 days, they stop the IV, and that's good. The patient is better, so your workup is negative for infection, you stop antibiotics. But then they decide maybe she has a pneumonia. The X-ray is slightly abnormal. Let's give her 7 more days of Ceftin. So she goes back to the nursing home with 7 more days of Ceftin. Third admission in a few months again. These are real cases actually I took from my collection of cases. The patient has fevers, chills, and abdominal pain this time. What does she get started on again? Vancomycin and zosyn. Her CT is this time positive for sigmoid diverticulitis, so there is definitely something going on here. And she started on appropriate antibiotics because zosyn is a good antibiotic that covers gram-negative bacteria in the abdomen, enterococci, anaerobic bacteria. Probably the vancomycin didn't need to be started there. But then the blood cultures were positive for gram-positive cocci, so vancomycin also makes sense that we need to know what the gram-positive cocci is. Patient was in the intermediate care unit, deteriorates, get hypotensive, rapid response is called, moved to the ICU, get started on pressors, her fevers don't effervesce, and she's been on 2 to 3 days of antibiotics, still febrile. So what's going on here? Her blood cultures are positive for vancomycin-resistant enterococci. So this is a patient who is septic, who's been in the hospital for 2 to 3 days and not on appropriate antibiotic therapy. And rapid response had to be called and she had to be moved to the unit. So now I'm going to talk about enterococci and just focus on VRE. Enterococci are gram-positive bacteria. These are round, these are pink, and they actually used to be initially classified in the family of strep, but they are now classified as a totally different family. All of us have enterococci in our abdomen. We carry them in the human intestines, urinary tract. They usually cause urinary tract infections, intra-abdominal infections. But normal people should not be susceptible to this infection unless there is exposure to antibiotics or there is some kind of stress, basically. And there are 2 species of them, fecalis and faecium. So enterococci cause UTIs, intra-abdominal infections, but what can happen also is because of very good blood supply in those areas, these bacteria can also enter the bloodstream and cause bacteremia. That's what properly happened in that patient. And actually that patient, because of delay in starting the right antibiotic, she also went on to develop an abscess. She needed a surgical procedure to drain the abscess. So she was transferred to the unit, increased length of hospital stay in the ICU, and in general hospital stay, and also a surgical procedure which probably could have been avoided if she was started on the right antibiotic early on. So usually we treat the enterococci with ampicillin or vancomycin, but VRE are resistant to vancomycin. The risk factors for VRE, the biggest risk factor is vancomycin use. And it's not just vancomycin, any other antibiotic, particularly cephalosporins, other beta-lactams. All these are risk factors for developing the VRE. Immunocompromised patients, transplant patients, neutropenics, dialysis patients, they are at higher risk. And I mean, what's the common among all these patients? They're more susceptible to infections, so they're going to be exposed to more antibiotics. A lot of hospitals actually have closed units for transplant or oncology, so increased risk of transmission also. So, and also admission to ICU for the same reason. Vancomycin resistance is it's been reported in the studies as an independent predictor of death from enterococcal bacteria. And as we saw in our patient, prolonged ICU stay, increased risk of surgical procedures, increased cost of stay. So that's why we need to control them. This is no-brainer. In this slide, actually, they're talking about kilograms of vancomycin used in hospitals and increasing resistance of vancomycin for the enterococci. So that's why we need to control the antibiotic use. And it's not just antibiotic exposure, as I said, it's also infection control, because VRE can be transmitted from one patient to other through unwashed hands of a healthcare worker. Not only that, if you are actually examining a patient with VRE with your own stethoscope, you're not washing it or cleaning it, and you're using it on the next patient, because the VRE can actually survive on the stethoscope for 60 minutes. And they can also survive on the other hospital equipment up to 7 days. So if the disinfection is not done, that's a mode of transmission as well. So as I said, if you're not washing the hands or unclean stethoscopes, bed rails, countertops, you name it, any of the hospital equipment can transmit VRE. This is just something I just wanted to show. One of the earliest reports of VRE actually came in Europe, where they were using this feedlot that had avopersin, which is a glycopeptide related to vancomycin. And those cattle developed, or they started getting colonized with VRE. So those who ate the meat from the cattle, or pets that came in exposure to those cattle, the VRE was transmitted, and the individuals were colonized, and then under stress, when they got infected, they got into the hospital, then transferred to other patients, then discharged, came home, household transmission. So this cycle continues basically. So it's not like animals are free or they don't carry VRE. I mean, like if you take MRSA, pets have been known to be colonized with VRE. I just had a patient, even after decolonization, multiple times with bacterial chlorhexidine, he kept on coming back with MRSA skin infections. And then we actually found out he had a dog. And we said, okay, let's decolonize the dog as well. And that's when it stopped. So, and I just wanted to show this. It's just showing a busy ICU, and we would think probably we'll find the bacteria here where the patient is laying, the bed rails, and all this area closed. And let me show you the next slide. When an ID doc who really wanted to know and had a lot of time in his hands swabbed all these areas, they found these drug-resistant bacteria all the way up here on the monitors, this upper part of the curtains, these panels here, and just everywhere. Because some of these bacteria can also actually be transmitted by aerosolization. So the treatment, obviously, we know vancomycin doesn't work because these bacteria are resistant to vancomycin. So what do we use to treat the daptomycin? But we can't use daptomycin to treat the fecia. It's just for the fecalis, and linezolid is the drug of choice. Sinercid is a very toxic drug. I try not to use it because of its toxicities, and but otherwise, that's one of the options for treating VRE. If some of the VRE can still be sensitive or susceptible to ampicillin, so that still will be an option, even if they're resistant to vancomycin. So we just have to see. That's the reason we would like to restrict the linezolid, the daptomycin use, so that we are not losing these also as options. I've seen cases where the linezolid MIC, I mean, it's still not resistant, but it's creeping up. So the next thing we'll see is resistance to linezolid and daptomycin. So we really don't want to go there. And it's not just treating it. So the biggest thing about is limiting the transmission, contact isolation, no shared rooms, proper disinfection as we talked about, and PPE. Making sure that they're worn prior to entering the room, and we remove them before getting out of the room. We do have stethoscopes that are dedicated to the patients who are in isolation. Same thing about thermometers, big cups, not sharing them. Limiting the vancomycin use, big thing. And how can we limit it? Our sepsis protocol, anybody who is coming in with sepsis, what do they get started on? The vitamin B and C, vancomycin and zosyn. And if somebody is septic, you really don't, I understand that, at least try to we have come up with this organ-based way of choosing antibiotics for sepsis. If somebody is coming in with some intra-abdominal pathology, just like this patient I discussed, there's no need to put that patient on vancomycin. Zosyn should cover most of the intra-abdominal pathology. But if it's a dialysis patient, we don't know what's going on, is coming in with sepsis, it does make sense to add the vancomycin. So we really have to be picky about where we use the vancomycin, because and also the proper dosing of it. It's not just not using or using vancomycin. The dose has to be right, because if we use vancomycin and we underdose it, we're really helping the bacteria to get strong and resistant. And last but not the least, hand hygiene. I can't stress enough about that. I have a few questions I took from one of the CMEs from Mayo. I thought this is just a good gist of what we talked about VRE. Which of the following patients is likely to be colonized with VRE? A 25-year-old woman who was admitted to the hospital for ectopic pregnancy, or a 65-year-old man receiving a 1-week outpatient course of antibiotics for community-acquired pneumonia, a 40-year-old man on the oncology unit receiving high-dose chemotherapy for acute myelogenous leukemia, or an 80-year-old woman with CHF who lives alone at home, or a 50-year-old man admitted to a general medical ward for cellulitis. Any takers on this?
40-year-old.
40-year-old.
Yes, great. So there's an oncology unit, high risk of infection, probably increased risk of antibiotic exposure, and also if it's a closed unit, like some hospitals have, increased risk of transmission as well. The next, which of the following is the likely portal of entry for an 85-year-old female with VRE bacteremia? Venous stasis of the lower extremities with intact skin, or lower respiratory tract, or urinary tract, upper respiratory tract, blood transfusion. Urinary tract, right. Which of the following is the best treatment option for VRE? Linezolid, chloramphenicol, gentamicin, ampicillin, trimethoprim sulfamethoxazole. Linezolid. This question is a bit tricky, but really, I think here they're trying to really get at the Zyvox being the drug of choice, but if you look at the susceptibilities, and if ampicillin is still susceptible, that's a good option for treatment, so we don't need to go for Zyvox. Also, gentamicin actually is used to treat enterococcal endocarditis or bacteremia in certain situations, but it's only used as a synergy, in synergy with other agents like Zyvox or ampicillin. You never use the aminoglycoside alone. Which of the following is the treatment for a patient who has a positive rectal swab for VRE? I didn't talk about this, but we'll do a small discussion. So we do surveillance for MRSA with a nasal swab. They test positive, and some of them, I mean, in our hospital we don't do routine decolonization, but in someone who has had several infections in a year or something, we do the Bactroban or chlorhexidine washes. So the way we actually do the surveillance for colonization for VRE is by a rectal swab, just because of where the bacteria colonizes, usually the urinary and the abdominal tract. So if somebody tests positive with a rectal swab for VRE, what do we need to do with them? Do we treat them with Zyvox? Do we do Zyvox bladder irrigation? Do we give them IV gentamicin? IV chloramphenicol? Or just observe for any signs and symptoms of infection? Any takers on this? Just observe. Yes, there's nothing, there's no recommendations about decolonization for VRE, at least as of now. Rectal swab for VRE to detect the colonization, and there are no guidelines to do decolonization routinely. And CDC does not, as of now, recommend for pre-admission screening routinely either. There are some studies that have shown in very, very specialized units. When I was in Mayo and in the transplant unit, between transfers, they would do, they would swab for VRE colonization and put them in isolation. But it's where some centers do it between transfers, but really there is no wide evidence or We don't do that, at least in our hospital as of now, and the CDC does not recommend it routinely. So why don't we all go to a nice place like that, where maybe it's too cold and the bacteria cannot survive, right? So this is the most recent article I saw. We are found in Arctic birds. So I don't think there is any place that we can do an escape from this MDRO. So just clean hands and save lives here. And this is about VRE. And now I get into a little more complicated topic about the ESBL organisms. And these are just growing in number every day. Before we go into this discussion, again, I have a case. So this is a 58-year-old male admitted with sepsis, fecal peritonitis, ICU admission for more than 14 days. Hospital course complicated by enterococcal bacteremia. This patient also had penicillin allergy, so he didn't get Zosyn or any of those. So we really had to choose antibiotics based on his allergy. So this patient didn't get ampicillin for the enterococcal bacteremia. He actually got vancomycin. He also had candidemia because of his abdominal pathology. So he got fluconazole. He also developed ventilator-associated pneumonia secondary to pseudomonas, and he received cefpime. And this is a patient I saw in this hospital. Antibiotics received 2 weeks of IV cefpime, fluconazole, vancomycin for 2 weeks, and flagyl. New onset of fever while he was still on these antibiotics. Blood culture is positive for gram-negative bacilli. This is reported as ESBL E. coli. So let's go into the discussion. What are ESBL organisms? Extended spectrum beta-lactamase producing organisms, which we shall call as ESBLs. And before we go into that discussion, we really need to know a little background, just like the other one. What are beta-lactam antibiotics? The penicillins, cephalosporins, carbapenems, these are all beta-lactam antibiotics. That means they are cell wall active agents. They prevent the final step in the synthesis of the gram-negative cell wall. I'm not going to go into all these details, but broadly, these are all the different penicillins, the different cephalosporins, the carbapenems like doripenem, meropenem, and they have very broad spectrum coverage. Like if there's some anti-pseudomonal beta-lactams like cefpime, Zosyn, they're also active against Staph aureus, Enterococcus. So humans found the beta-lactam antibiotics to fight against these microorganisms, and what do the bacteria do? They produce a beta-lactamase. Beta-lactamase is an enzyme that the bacteria produce to provide resistance against the beta-lactam antibiotics. And they're produced both by gram-positives and gram-negative bacteria. And these beta-lactamase enzyme is transmitted from one bacteria to the other very easily using plasmids. So the pili that you're seeing. So it's just a very easy way of transmitting this resistance from one bacteria to the other. And bacteria are generous, they're promiscuous, they just keep on transmitting this enzyme from one bacteria to the other. So there's no end to this process. Okay? So what are the ESBL producing microorganisms that it is that we know of as of now? Maybe there'll be more after a few years, but E. coli, Klebsiella, Pseudomonas, Acinetobacter, and other Enterobacteriaceae. These are all gram-negative bacteria. When these bacteria produce, or these are ESBL producers, that means they are resistant to the penicillin, so you can't use Zosyn, Noxacillin, or any of them. We cannot use any of the cephalosporins, but still they are susceptible to the carbapenems, like doripenem, meropenem. So the choice of antibiotics here is pretty limited. So the bacteria, so we first produce the beta-lactam antibiotics, the bacteria produce the beta-lactamase, then what do the humans do? We find an inhibitor for the beta-lactamase. And those inhibitors are clavulanic acid, or the tazobactam part of the piperacillin, or if you take the augmentin or unicin, the sulbactam or the clavulanic acid part, those are inhibitors, which means they inhibit this beta-lactamase enzyme. So if you combine a penicillin, like if you take Zosyn, the piperacillin is the penicillin. If you combine with this inhibitor called tazobactam, it can still be susceptible to this ESBL producing organisms because we are combining it with the inhibitor. but that still is not going to last long. And some physicians still use it, but technically your person is still inactive. So you're just trying to rely on this inhibitor part. So unless the lab does 1 or 2 tests and is pretty confident about it, I'm not comfortable using that. What are the risk factors? Obviously the big thing is antibiotic exposure, and most of the other things are the same as the VRE. Healthcare setting, ICU admission, immunocompromised patients, recent surgical procedures, prolonged mechanical ventilation, other comorbid conditions like diabetes, heavy alcohol use, and stage renal disease. But pretty much everything comes down to extensive antibiotic exposure and increased risk of transmission in closed units for all of this. And the same thing, what I'm saying, where patient gets admitted, he's colonized, he may not have an infection. If he gets transferred to a long-term acute care facility, so from there, the other people get colonized through unwashed healthcare workers' hands. From that, somebody else gets admitted. So this cycle goes on actually between the community and the hospital. How do we treat ESBL bacteria? Carbapenems like doripenem, meropenem, imipenem, ertapenem. Colistin. Colistin is a very, very old drug that we actually stopped using it because it was so toxic. People would end up with seizures, renal toxicity, would end up on dialysis. So now we have brought it back because now we don't have any options to treat these bugs. It has to be very carefully monitored. I had one patient who actually had I saw him in subsequent admissions, but when he came to me, he had a very drug-resistant Pseudomonas, and he told me the last time he received colistin, he ended up with seizures, ended up on a vent. And the only option he had this time again was colistin. So this is a very toxic drug. And as I said, zosyn or unicin, when you come, because they are combined with this inhibitor part of them, like the tazobactam or the sulbactam. There is not much research going into getting new antimicrobials just because there is not much money into it. Imagine all the money a drug company puts into getting a new antibiotic. And what is the first thing ID docs say? Restrict it. So it's a good thing. We're trying to restrict it and use it judicially, but for a drug company, if you look at from their standpoint, it's really not lucrative because even if we use it, how long do we treat an infection with? Maybe 2 weeks, an osteo for 6 weeks or 8 weeks, and that's it. But if they put all that research into a cardiac drug or something that's more long-term, their returns will be much more than into an antibiotic. And also the big thing about restriction, if a new antibiotic comes out, the first thing we say is restrict it so that it's used judiciously. So there are not many gram-negative drugs in the pipeline for the next several years. So if we run out of these options, we don't know where to go next. There is one drug we still are not using widely in US called fosfomycin, which Europe uses a lot for ESBL, so that's still an option. So that's about the ESBLs. And so once we start using doripenem, meropenem, imipenem more for the ESBL bacteria, what do we get? Carbapenemase producing organisms. And these organisms are resistant to meropenem, ertapenem, doripenem, and imipenem. These have been seen with Klebsiella and E. coli, and also with other gram-negatives like Proteus, Serratia, and Salmonella. If we lose carbapenems also as an option, we're only left with colistin or fosfomycin. Both are very toxic drugs, and fosfomycin is not even widely available here. So. And let me give an example of what happens in this. Also, the situation in this case is there is a delay in treatment, as we talked about in the earlier case with VRE. We all know that in a septic patient, the antibiotics have to be started as early as possible once the patient gets to the hospital. And if we find out on day 3 or day 4 of admission that a patient has a carbapenemase producing organism, there's already a delay of 3 to 4 days to get the patient on the right antibiotic. So that's why increased risk of surgical procedures, increased ICU stay, and all these other things, increased cost of the hospital stay. So all these things that we talked about. Infection control is the key, along with antibiotic restriction. The same things repeat, the same things as for VRE, contact isolation, clean your stethoscopes if you're using your stethoscope to examine the patient, because I know sometimes those yellow ones, They're not really that audible, and a lot of people don't like them, but if you're using your stethoscope, just clean it, because stethoscopes are a very important factor in transmitting these bugs. And also PPE, prior to entering the room and removing before exiting the patient's room. Hand washing, and hand washing. I can't stress enough about that. I just wanted to show this. How many of you have heard on the news recently about this new superbug called NDM1 that was isolated from New Delhi? It's named after a city. Now they have run out of names to name these bugs, so they're starting to name these after cities. So this one is called New Delhi Metallobetalactamis 1. So, and what this is showing is, it's just a very complicated map, but what they're showing is when they found this bug in New Delhi, they tried to get water samples, and they actually found that the water system of the city was carrying this bug as well. So imagine, you don't need to have any risk factors, you don't need to have anything, just if you're drinking that water, you probably are getting exposed to that bug, and you're getting colonized with this. And this is a carbaphinamase producing bacteria resistant to all antibiotics except colistin. So I thought I should show this, because it's not just all these risk factors we talked about. And I can at least speak for India, because in India, or in a lot of countries in Europe, you don't need prescriptions to get antibiotics. You walk into your pharmacy, you ask for an antibiotic, you get it. So there is very high antibiotic exposure there. And there is probably, they're not probably dosed right. As soon as they get better in 2 days, they stop it, so they don't complete the course. So that's why we're seeing all these drug-resistant bacteria. And now with increased travel from all these countries to here, so this bug is now just not restricted to New Delhi. It's there everywhere. It's seen in Europe, it's seen in several other countries. When I was visiting India recently, my daughter, she's 3 years old, she had fever, so I went in just to buy some Motrin. And that's all I was buying. So the pharmacist actually asked me, okay, do you want to take some Augmentin too? So he actually decides what, and he offers it to you. So, and that's how it is back there. They don't need to, the local pharmacy just serves as a mini clinic, and they dispense drugs just as they want. So it's, again, this is exactly what I was talking about, antibiotic stewardship and restriction. It's not just about choosing the right antibiotic, stopping the ones. It's okay to start broad antibiotics when a patient first comes to the hospital, but by 48 hours or 72 hours, you should know, what are we treating? So de-escalate the therapy based on the cultures. Restrict the formulary so that not everybody who's coming to the hospital is getting started on daptomycin or Tyvasin or Zyvox, so that we're saving these drugs. And make sure the dosage is right. That's why we need pharmacists who have the background training to dose these antibiotics right. Otherwise, if you're not putting enough pressure on the antibiotics, or we're not using the right dose, increased risk of resistance. And also right duration of therapy. It's very important, especially for MRSA, Enterococcus, or any of these gram-negatives. It's very important that we, for pneumonia now, ventilator-associated pneumonia, for some of them, they say 8 days. Maybe for Pseudomonas, you want to go up to 2 weeks. Don't stop it short. Just make sure you're giving the adequate therapy, but also not extend the therapy when it's not needed. Same thing I was trying to say. If you don't give the right dose of the antibiotic, you're making them stronger. And this whole thing is not new about infection control, antibiotic stewardship. This is actually a paper from 1970s. And where did I put this? Here they're talking about how the rate of infections from Klebsiella went down after they started restricting the antibiotics. So it's really not new. It's been there now for 40 years, and we're still working on this. So again, the same thing. If you don't use the right dose and the duration, you're going to make the bacteria get more resistant and get more strong. So that's about ESBLs, carbaphinamase producing organisms, and VRA. Now I'm going to go into the next thing, which is Clostridium difficile infection, which we see when we overuse antibiotics. this patient, again, is from my collection of cases, 67-year-old male with history of recurrent pneumonia, COPD, diabetes. This patient was actually getting admitted almost every other week, that someone decided, okay, let's leave you on a low dose of Levaquin so that you don't get back into the hospital and you're not getting any more pneumonia. So this patient was on several weeks of Levaquin, actually, before he got admitted with abdominal pain, diarrhea, fever, and a white count of 45,000. And his CD abdomen showed colitis. And obviously this is antibiotic-associated colitis or Clostridium difficile colitis. What is Clostridium difficile? It's a gram-positive anaerobic bacteria that we all carry in our gut. It's just under antibiotic pressure, this bacteria multiplies and start producing the toxin, toxin A and B, which causes colitis. There are two phases of the growth phase. There are two different phases in the C. difficile life cycle. One is a spore, which is a more dormant phase, and the other one is the growth phase, where the bacteria is multiplying and is producing the toxin and the clinical symptoms. So again, as I said, we all carry this bacteria, so it's not something, the toxin-producing bacteria can be transmitted, but it's present in the gut. 10 to 20% of hospitalized patients are colonized with this, and up to 15% of healthy adults carry this bacteria in their gut. And the percentage is much higher in the neonates. And also you can actually get the disease-producing or the toxin-producing strains from unwashed healthcare workers' hand or hospital environment. So again, as I said, the most common route of transmission is fecal-oral route. And I just want to mention one thing though, not all antibiotic-associated diarrhea is from C. difficile. It's only 15 to 25% of it. There are other bacteria that also can cause antibiotic-associated colitis, like Klebsiella and several others. So what happens if we take antibiotics? There is alternation in the normal bowel flora. So there is increased colonization of the C. difficile. It's growing, it's producing the toxin, and that causes the symptoms. And the other risk factors, obviously, again, as we talked about, advanced age, immunocompromising conditions, long length of stay in healthcare settings, GI surgery, or any kind of manipulation intra-abdominally, and antibiotic exposure. Common presentation, usually abdominal cramping, fever. You can see white counts as high as 100,000 in these patients. It's called leukemoid reaction, and that's very, very characteristic for C. difficile infection. So if you're seeing somebody with abdominal pain, cramping, colitis, and they have a high white count like that, 60 or 100,000, it's most likely C. difficile infection. Hypoalbuminemia. In the most severe presentations, patients can develop toxic megacolon. They can also develop bowel perforation and require surgery, including colectomy. And what this is showing is, if it's very clear, these are those yellow stuff on the pseudomembranes. This is a section in it from a patient with pseudomembranous colitis. So it could be just asymptomatic colonization or colitis or toxic megacolon, as is shown in this picture, where the colon is completely dilated. In this particular presentation, you're not going to see diarrhea. You're going to see ileus. So the patients come in with sepsis. They don't have diarrhea. All they have is abdominal pain. So it's really a clinical diagnosis, because they don't have diarrhea for you to send off a specimen for C. difficile and get a positive. So C. difficile infection doesn't always present with diarrhea, even though that's the most common way of presentation. In the most severe forms, it could be ileus, secondary to the toxic megacolon. And also patients can develop perforation or peritonitis and require surgery. Treatment, 1, 2, 3, 4, 5, discontinuing the antibiotics. Next, anything comes next. Flagyl, oral vancomycin. Inpatient, the treatment for C. difficile, we're really trying to target this bacteria that is multiplying in the colonic wall. So you should give any of these drugs PIVO. If someone has ileus and you can give it PO, vancomycin can be given as an enema. So that's the way we do that. But sometimes we do IV flagyl, but there is no evidence to show it really works. And we have no option. We try to do whatever we can in a patient who is septic. So we're trying to give vanconemas, we're giving IV flagyl. But really, if you cannot give anything by mouth in a patient with C. difficile who has perforated and is going for surgery, then really it should be vanconemas. Probiotics, there's still a lot of research going into this. Even though the article from the Clinical Infectious Diseases says Saccharomyces is superior to the others, there are a variety of probiotics that physicians are using. The best thing is just if you can get a cultured yogurt and use it, that's the best. Colectomy for severe cases. I did not mention here fecal transplant because it's still not widely available. But what fecal transplant means is that the reason you're having C. difficile infection is because the C. difficile bacteria has overgrown in the gut of the patient with C. difficile infection and is producing the toxin. So you want to give them back all the normal flora. So usually what they have is have a family member donate their feces, and it's given as either as an enema or through an NG tube. And that works. And there are several cases. I haven't read about any case where there has been any failure. We actually recently transferred a patient from our hospital for fecal transplant at another institution, but it's not widely available yet, but it definitely works. This is actually the culture, the agar plate from the gloved hand of a healthcare worker who was taking care of a patient with C. difficile, just showing how much burden of these organisms we carry. And it's not just the commode or the bed rail, as we saw earlier in one of the slides. It could be anything: stethoscopes, blood pressure cuffs, thermometers, sinks, floors, especially if somebody is having really bad diarrhea and they're incontinent, I mean all the floors. So you should really be also wearing the foot covers really before entering the room, which we don't do normally. But if somebody is incontinent and is contaminating the floors, along with the PPE, we should also be wearing the foot covers, because we can actually carry the spores on our shoes and transmit them from room to room as we go. There is a recent article that came out that these spores are so they're so tough that they can also be aerosolized in dry environments. So the transmission is mainly by the spores. These are dormant cells. They are very tough. They survive under harsh conditions, even high temperatures up to 70 degrees, and they can actually survive up to 5 months in the environment. So infection control and antibiotic restriction, again, are the key players here to decrease the incidence of C. difficile in our institution. Antibiotic restriction, private contact isolation, washing hands with soap and water, mainly because we're really trying to get the spores off our hands. So we should not be using alcohol to wash hands when we are taking care of patients with C. difficile, because the alcohol does not kill the spores. And patient care equipment should remain in the room. And how long do we continue the contact isolation? Do we follow them with the heat stool C. diffs? There is no evidence to show that once a patient tested positive, you need to repeat it if they are clinically better. Once their diarrhea is resolved, they're having formed stools, you can, for evidence, remove them from contact isolation. But if they're still in the hospital, better to keep them isolated. And use herbicidal agents for disinfection like bleach, as we do here. So alcohol does not kill the spores. Wash hands with soap and water. Same thing, the spores are not killed by the alcohol. So this patient gets started on flagyl, gets 14 days of treatment, gets better, goes home, is readmitted again in 4 weeks. What's going on? This patient either has a relapse of C. difficile or has a new infection of C. difficile. The patient is readmitted with diarrhea, abdominal pain. It's the same presentations all over again. And why is that? The reason we see patients having relapsing infection from C. difficile is all these antibiotics we use to treat C. difficile, they only treat the C. difficile in the growth phase. They do not kill the spores. So the spores are going to persist. And when they grow and come into the growth phase and start producing toxins, the patient will have symptoms again. So this actually can happen again and again and again. So the way we treat this infection, the relapsing C. difficile infection, is what we do is once we treat them for 14 or 21 days with oral vancomycin every 6 hours, we do a pulse dose therapy, which means after 21 or 14 days of the regular treatment, we make it twice a day for 10 days, then once a day for 10 days, then every other day for 10 days, then every third day for 10 days. So we're really trying to get all the spores as they're maturing. Or fecal transplant, basically. So that's pretty much covers all the multi-drug resistant organisms. As of now, maybe we'll have more by next year, I don't know. But increasing clinical problem, why they are important. They can cause outbreaks in critical care settings like ICUs or neonatology units. They're often multi-drug resistant, they are difficult to treat, and they're associated with increased mortality, morbidity, increased risk of surgical procedures, and increased cost of stay. Pretty much. So what can we do as healthcare providers? Being aware that they are out there, and also good infection control practices, antibiotic restriction, and just a team approach. Just having the infection preventionist, the clinical PharmD, infectious disease physician, all the nurses from all the different floors, everybody working together so that there is a team approach trying to control the transmission and also restricting the antibiotics. Do we have that when I emailed? Or?
I can pull it up real quick.
I just wanted to show you where we are with the Piedmont, with these ESBLs, and Deborah was able to pull up some slides for me. But pretty much I'm done with my presentation.
While
so
she's pulling those up, y'all want to ask some questions?
I just wanted to say, here at Noonan, on your face sheet with the patient and also on your health data one, we call the CPOs, we call them CREs. So when you see that, that's the organism that Dr. Mannepalli was talking about, and that's carbapenem-resistant Enterobacteriaceae, because there are so many different organisms that this ability can be in. Rather than have a whole list of them, I just call them that. And I've also added another column which should be going live soon after I test it, called Other MDROs, where we'll be listing history, where I'll put where if they have the ESBL or the other resistant organisms, because as you can tell from the lecture, there are more and more of them every month. So that's just where you can tell. And if you see a yes on any of those, MRSA, VRE, CRE, the other MDRO, put the patient on contact isolation. Once they're on contact, they'll stay there until either myself or Dr. Mannepalli gives the okay to take them off, because we need to look at the patient and make sure that whatever is going on has been corrected. Okay, any questions on that? Also with the C. difficile, they stay on until one of us gives the okay, because so, it's hard to tell with some of these patients whether or not they could be in treatment and if they've resolved their symptoms.
This is just the Piedmont system, where we are with our ESBLs. So if you see the trend from 2008 to 2010, there was an increasing percentage, and as of 2010, 3.1% of E. coli isolates are ESBL producers. If you look at Klebsiella pneumoniae, same trend. We're seeing more and more resistant organisms. 7.3% of Klebsiella pneumoniae are ESBL producers, and for Klebsiella oxytoca, from same trend increasing.
Currently, we have Clorox wipes available that you can use to clean up equipment for patients that you know or suspect have C. difficile. Okay, you can use that. We're trialing some PDI wipes which also contain bleach, and they'll have I believe it's like a gold cover on the top, the lid, instead of the purple or blue or whatever. So they'll look different, but they also contain the 1 to 10 concentration of bleach, just like the Clorox wipes. We're trialing those to see if the staff like them as well. Corporately, we're looking at going to those instead of the Clorox. I believe there's some price savings in there. You know, if it's a comparable product and it works as well for us, we'll make the switch, and that's why we're evaluating them. But it's very important, if you have a patient that you know or suspect C. diff, to clean every piece of equipment that comes out of that room with a bleach wipe, including your stethoscope, which is why you may want to leave yours outside and use the yellow one. You know, just to keep from getting yours contaminated and then having to clean it every time you come out of the room.
If there's nothing else for Dr. Mannepalli, we certainly appreciate her and her expertise. Please thank her.
Thank you.